What is knee arthrofibrosis and how we diagnose it? As we know, this is still one of the most undiagnosed, poorly treated orthopedic pathology. It affects quality of life of patients, and so we should do a bit better than what's the common practice worldwide. And hopefully, this webinar will help. Just a little bit about me, so that you know who I am, what I do. I'm a physical therapist. I'm a biomechanist. And I'm completing a PhD on ACL rehabilitation, which means I'm still anyway researching around the knee. My PhD is in Ireland at UCD Dublin, but my clinical practice, where we have multiple clinics, it's in Switzerland. And in Switzerland, I also, as you can see, I'm sorry, here I also work as a clinical researcher at the UC, which is a chain of multiple hospitals, and I work in orthopedic surgery. In this sense, because of arthrofibrosis is of my interest, I had arthrofibrosis myself, so I was a patient. I know it all. I went through it. Hence, I can, let's say, have a better grasp on what it means, even if it's always a subjective experience. For every patient is different. But anyway, we are also conducting research on the arthrofibrosis, and we're going to publish studies soon. I'm part of the board member of the IAA, the International Arthrofibrosis Association, and I co-founded and created basically in Switzerland the European Arthrofibrosis Center, which lately in the last years specialized a lot on this. We see patients from all around the globe, both on a physical therapy perspective and surgical perspective when unfortunately is needed. This is the board of directors. Again, Professor Kylie Asher that founded the IAA, Manon Raab, and myself. And then, board of advisory, we have multiple ones actually, and this is constantly evolving. Basically, the ones that have expertise in a specific field that's linked to arthrofibrosis might be orthopedic surgery, might be lab research or PT, etc., biomechanics. So we have involved some of them to help us out through the process. The goal of the IAA is, as summarized in these bullet points in this list, it is to connect patients and clinicians in order to offer the best practice, the accessibility to the best practice and evidence-based, or let's say evidence-informed, which is probably more appropriate in terms of treatment and research for, again, clinicians and patients. Also to promote, create, and sustain a movement to support, learn constantly. This is also coming from the experience of each of us. Arthrofibrosis as clinicians is not that easy. We need to grow together. Advocate, obviously, for education and research. This is also the reason why, if you digit www.arthrofibrosis.info, which is the website of the association, you will discover that as IAA, we evolved and we became a charity, a foundation. That's to support through donation from whoever, private donations, public donations, support the awareness worldwide, the ability for us to spread the knowledge and also research, which is how we intended the foundation when we moved the IAA towards that. And also to provide as much as possible and evolving throughout time, hopefully with a growing body of evidence and studies, a scientific background for information on the website, which means the website is constantly updated to make sure that you can find reliable information. At the same time, we are still dealing with the fact that unfortunately arthrofibrosis is not that diagnosed that often. It's often misdiagnosed, underlooked, and as a consequence of that, we should probably do, again, a little bit better than this, because the impact on patients' life, it is, as we know, absolutely relevant. So, because scientifically speaking, when we discuss about the phenomenon, we should understand the dimension of the phenomenon itself, how much this happens, because even if, as knee arthrofibrosis patients myself, even if that was obviously a life-changing experience, if that would be a rare pathology, well, we might spend a lot of time to discuss of a problem that is affecting just a very limited amount of people, which anyway would be a nice thing to do and an ethical thing to do. But the reality is that if we go through some studies, arthrofibrosis is not at all that rare. Specifically speaking, in this study, that after anterior cruciate ligament reconstruction, surgical, tracked the loss of motion, or the lack of range of motion, as you can see, out of almost 250 patients at follow-up 1 year, more than 11% had range of motion loss. And you can see that definition of that, which means at least no more than 120 degrees of flexion and missing at least 10 degrees of extension, which is a serious extension lack, by the way. Some of these patients also require surgery, but let's say bottom line, 11% of patients after after ACL reconstruction might end up in developing knee arthrofibrosis. And also, if we look at this same data in the pediatric and adolescent patients, it descends a little bit. We are slightly above 8%, but still look at the dimension of the sample. Here we are talking about more than 900 patients, which means obviously these 8% is even more solid. This is actually happening. It's happening in kids, 8%, and in adults after ACL reconstruction, up to 11%. That's not rare, not at all. Also, concerningly, if we check what happens through the study again in terms of the persistence of lack of range of motion extension-wise, so lacking terminal extension in patient after ACL reconstruction, at least at 1 year after surgery, after 1 year, one patient out of three, so 33% of patients are still missing at least 3 degrees of extension, which means the whole hyperextension is gone, and then we are missing at least 3 degrees of hyperextension. It's that's 1 year. It tends to reduce to 20-25% after 2 years, but still it is a major problem. What's underlooked is the fact that if we don't have our patients recovering hyperextension and at least terminal extension, they will have a permanent gait alteration and won't be able to fire properly their quad muscle. And here what we know is that we are dancing in between a quarter or a third of these patients that after 1 or 2 years are still not achieving complete extension, not to mention the whole hyperextension, which is gone. And this is concerning. We know the impacts of this, so we want to make sure that this doesn't happen. So to sum this up, what we might say is arthrofibrosis grossly is impacting life of post-surgical patient, and I didn't mention total knee replacement, meniscal repair, etc. But let's say on average, whatever surgery, probably we are talking about a 10-ish% of incidence. So that happens a 1 patient out of 10, which means it's not that rare. Don't not get into details in relation to what's incidence, what's prevalence, but let's say that again, if we track what happens in a specific moment, that's actually prevalence. And so the data that we saw before, those patients lacking at least 3 degrees of extension after ACL reconstruction, they were prevalence data. But anyway, we do have a problem. So if we look in what happens in the end, we should also analyze the word. What are we talking about when we mention arthrofibrosis? The word per se is still a bit unknown. In the end, it's arthro. It's a combination of arthro, which means joint, and fibrosis. So long story short, it is a fibrotic process inside, outside the joint, which also involves the capsule, making it more fibrotic, and I will go into detail, don't worry. In this picture here, which is clearly coming from a cadaver study, but anyway, what we can start seeing is that we have abnormal bridges, so bends or layers of fibrosis connecting tissues or structures that shouldn't be connected. So we have newly formed scar tissues, bends again, or let's say interlayers of scar tissues, or we have thickening of existing structures that also become fibrotic. And if you see my mouse, the arrow moving, that yellowish body here, that's a fat pad. The Hoffa fat pad should be by definition fat, which means yellow in that sense. It's highly innervated, but when you have a fibrotic process happening, this tends to become more fibrotic, which means it's infiltrated by fibrosis, becomes stickier, and adheres to other structures like the patellar tendon, which is this structure here, which is wavy now because of the position of the knee, and also what's behind. But we'll talk about this later into detail. So it's an orthopedic complication. We need a trauma, we need an insult to make it happen, which is most often the injury and the following surgery. Certain procedures, certain injuries, they sort of bring with themselves a higher risk of developing any arthrofibrosis. We'll go through it. But the point is, it's a sort of an uncontrolled inflammatory process. So the healing response, rather than being physiological and controlled in a sense, it just lasts for much longer, and also its intensity and acuteness and the peak of inflammation, everything is overrepresented. Chemically, what happens is basically that normal release of inflammatory cytokines, but in general, inflammatory cells, growth factors, and etc. This leads to a proliferation of the fibroblast into myofibroblast. I don't want to get into technicalities, but this should not happen beyond a certain limit. And when you have myofibroblast taking over in an uncontrolled way, that's when we have issues, because that in the end leads to proliferation of scar tissues, which again, it's the growth of unhealthy and tissues that shouldn't be in the joint and shouldn't affect also the peripheral joints. So for instance, the peripatellar structures and tissues, namely retinaculi, the capsule, the medial collateral ligament, and etc. What happens is again that sort of this inflammatory process never ends and it persists because of the myofibroblast overrepresentation, and this leads to more fibrosis over and over. There is also a graphic representation here. There are different ones in the literature, but anyway, again, it's quite technical, but as you can see, there is basically an unregulated activation of the myofibroblast, which at a certain point become the trigger or become the element that leads to the formation of fibrosis. We might say that this happens in the knee, but it's actually the same process in every joint, every fibrosis in every part of the body. In the liver, for instance, or in the shoulder, we're talking about the shoulder, the frozen shoulder, it's always the same mechanism. What happens per se? What we know that is in the knee, it's mostly affecting quality of life because it's not that much of a compliant joint. It's a loading joint, and patients, they end up having severe disabilities sometimes, especially if you cannot extend or severely have a severely limited flexion. Then obviously everyday's life is impacted. Anyway, this can also affect nerves, which is coming with the CRPS sometimes, which is the acronym for complex regional pain syndrome. But this will be covered later. But the point is, in the end, there is an injury, there is a trauma, possibly surgery, and then accompanying factors such as bleeding and poorly managed in the acute phase, poor management of the orthopedic management of the injury, and then physical therapy, which is not optimized, sometimes even surgery, they can just add up and create more problem. This ends up in an uncontrolled inflammatory process, which is hypoxic in nature, because that's what happens when there is a unregulated activation of the myofibroblast, and abnormal healing response with this process kicking off of forming scar tissues. Signs and symptoms for patients: this means losing range of motion, flexion, extension, or both. Having a very stiff patella, which again is lost in terms of range of motion. The patella can also evolve into a position which is called baja or infera, which means as a lower patella. And the tissues tend to become thicker, shrinked, and less compliant, which means again, patella doesn't move because there is a lot of resistance around the patella. And if you have a stiff patella, in the end, the knee most likely won't work that well. Pain, sometimes it is a problem. There is a sensitization of the nervous system. It is not mostly the main issue. The main issue is the stiffness and what's called by the patient the cemented knee. And also you can clearly see inflammation is overrepresented because of the swelling, but above all because of the fact that you have a red and very warm knee that reacts to everything, which means a patient that is just progressing through rehab normally can leave crutches after a while, depending by the procedure, and it just the inflammation just resolves by itself. It's a physiological process, but in this case, we are in a pathophysiological inflammatory process. It just keeps working against us, against the patient, and we need to find a way to control it. And again, this leads obviously to limitations, functional limitation, muscle weakness, and atrophy, and etc., with a high psychological impact because of the disability that is coming with it. We need to make sure that it doesn't become permanent, and that's what we're going to cover later on. Anyway, pain-wise, as I mentioned, can be part of the deal, can be part of the problem, but also pain is risky as a parameter to evaluate how things are going, because sometimes pain arises later. And so loud, it is always something, a provoking factor that we need to handle carefully. And most of the time, the knee reacts getting warmer, getting stiffer, rather than becoming more painful. Can also be painful, but that's something that sometimes happens with a certain delay. But obviously, we don't want these patients to be in pain, which means if the knee of the patient doesn't bend, cranking the knee, forcing flexion is obviously the worst possible approach. You would just provoke more pain, more inflammation, and in the end, more fibrotic reaction, which is not what we want. The more pain, the less movement. What we need is gentle movement, and we will go through this. There are primary drivers and secondary drivers of knee arthrofibrosis. I'm going to focus mainly on the first ones on top. As I said, the insult, either surgery, trauma, or both, can be followed by triggering factors such as immobilization. You think about a fracture, for instance, it's mandatory treatment. You need to immobilize the patient, but we know it increases the risk of arthrofibrosis. At the same time, a lot of times, unfortunately, the patients are immobilized because just of poor management. It's just not, they shouldn't have gone through that approach. Bleeding, obviously, and obviously surgery when the knee is still in a very acute stage after an injury. So inflammation, if it's peaking after an injury, needs to be resolved, or anyway, we need to give the knee to sometimes to calm down, to settle down inflammation. Otherwise, we will have this knee in the OR, in the operative room, way too reactive. The hypoxia is one of the primary drivers as well, and we went through why this process leads to lack of oxygen locally. There is unfortunately a genetic predisposition, which is at the moment impossible to detect in advance, which is obviously what we are all looking at and looking for. And we would like to, research-wise, throughout research, to get to the point in which we can screen patients pre-op and understand who's going to develop it. But at the moment, we just don't know. We know some patients react in a very scarring way, in a very aggressive way for whatever reason. Most probably there is some genetic predisposition behind that. The inflammation and potential infection, which is leading to even higher level of inflammation, they are definitely triggers. So now you sort of have an overview of the situation. Secondary drivers, I don't want to dismiss all the other ones, but I would much more focus on the bottom left, which is aggressive exercise on the affected limb. Aggressive physical therapy, having patients going through pain, never pays off. It's just a wrong approach. It's a very old school approach, and I'm not blaming anyone. We basically have no training in med school and either no structured way to learn what arthrofibrosis is also in physiotherapy school. But in the end, that's not a justification. We need to change that. So cranking the knee of a patient to obtain more flexion or forcing extension just for minutes, just gonna bounce back. It's just gonna play against us. It's a losing game. So how the knee should evolve. After whatever surgery, it doesn't matter. You can stretch these 2-3 weeks to a longer period if it's a multi-ligament injury, for instance, or if we're talking about a tibial patellar fracture. The bigger the injuries, the bigger the injury, the surgery, obviously, the longer it will last, the longer it will last the inflammatory phase, the acute phase. But sooner or later, anyway, it should resolve. It's normal to have a warm, painful, swollen, red knee with clearly reduced function. But after a while, it could be a week after a meniscectomy, it could be a couple of weeks after a meniscal suture, or even an ACL reconstruction, maybe longer if there are multiple structures involved and the surgery was more invasive. After a while, things should settle down. If they don't, something is just going in the wrong direction, or is going south, as someone used to say, which means probably the inflammatory process is looping, and we need to look out for that and recognize it. Again, the original injury might predispose to higher risk of arthrofibrosis. Articular fractures, such as the tibial patellar fracture, is definitely one of the worst, but also condyle fractures, femur fractures. But in general, fractures within the joint, they are unfortunately a problem, also because we need to immobilize these patients after surgical intervention quite often. The bleeding, the hemarthrosis, and in general, the bigger the injury, the worse it is. Multi-ligaments, dislocations, and etc. As we mentioned earlier, infection obviously leads to peak of inflammation, and the big injuries such as extensor mechanism ruptures, patella tendon ruptures, quad tendon ruptures, unfortunately lead to these as well. The total knee replacement has quite often also an outcome with a stiff knee, and I personally believe we are just not tracking these patients enough in research. A lot of patients just let's say, settle and accept the fact that their knee is not bending as it used to. They no longer have pain. They had bad knee osteoarthritis, but then maybe they are lacking a little bit of extension as well. All these patients are just not tracked in the literature, or the majority of them. In the clinical experience, what we see every day is that a lot of total knees tend to stiff up, and we need to make sure that from day one that this doesn't happen, or at least to apply the best strategies, put in place the best strategies to avoid that. We'll cover it. Treatment-wise, also treatment can be the cause. Sometimes the ACL reconstruction, the graft is not placed where it should. Again, prolonged inflammation. Using the tourniquet in the OR can be a trigger because the tourniquet leads to hypoxia by definition, which means can be a problem. We have data on this actually. We know that surgical procedures can be performed, total knee replacement, quite interiorly, most of the surgical procedure, but the ACL reconstruction, they can be performed perfectly safely, in a safe manner with no tourniquet. In the OR, we never use it. Obviously, I'm a physical therapist, I'm a biomechanist, I don't operate patients, but I'm quite often in the OR. We never use the tourniquet, but that should be a guideline. It's just us. In many places where arthrofibrosis is in which they specialized in dealing with these patients, tourniquet is not used, and etc. Okay, let's go ahead. Let's say that we have two stages of arthrofibrosis. One is active, which means it's really happening. We are booming. The inflammation is boosting, and we are in the very acute phase, which can last longer. It can be 4 weeks, 6 weeks, 12 weeks. Sometimes this acute phase, they're just really stretched for a long time. But that's when scar tissues are still forming, and we need to calm the knee down in terms of reducing inflammation. Residual arthrofibrosis, it's sort of the results of everything. Okay, so the inflammation settled down maybe 6 months later, maybe even longer. If there was a trigger cause that was fixed, and we will see about this in the diagnosis slides in a while, in actually 1 or 2 minutes. But let's say residual arthrofibrosis is what we are dealing with at the end. It's no longer the phase in which scar tissue is forming, but it's actually the results of the formation of scar tissue, so the established phenomenon. And in between, let's say we have the the shades of gray. You can, 10, 100, and 1,000, whatever, you name it. You number them. But the reality is it's really not easy to understand who's who. A lot of patients are clearly in the active phase, some others in a residual phase, but a bunch of patients are actually in between, and it's not that easy. That's why load and the progression of rehabilitation should be carefully programmed and planned. But this webinar is not about how to rehab a knee with knee arthrofibrosis, it's actually on how to diagnose it. And again, referring to the active and the residual stage, that's what happens pathologically in arthrofibrosis. But if you look at the graphic representation above, that's just healing. And healing happens with let's say with an inflammatory phase that usually doesn't last that long. It lasts days, can last weeks, but after a while, there is a second phase kicks in which the tissues start a remodeling process, a maturation process. And this should happen somewhere in between weeks after a trauma and surgery, for instance. This does not happen that soon. The inflammatory phase, again, the inflammation phase lasts much longer, causing the scar tissue formation. In general, healing happens. Most of the healing, 90%, happens within the first year, and then we still have a residual 10% or whatever it is, 8, 9, 10, 11, doesn't matter. But we're saying that the minority of the healing is still happening, a minor part of it in the second year, in which tissues still are somehow remodeling slowly. But the point is, if we have an established arthrofibrosis and we have the patient and we need to try to see if once we make the diagnosis, the way we go through together, and we are, let's say, here we are 7 weeks after surgery, whatever surgery, let's say ACL reconstruction or total knee replacement, we still have a window of opportunity to sort of revert the process because we are in the healing phase, probably inflammatory phase if we diagnose arthrofibrosis as such. Hence, we can influence healing. Clearly, if we see someone 2+ years after a total knee or whatever was the inciting event with a residual arthrofibrosis, a cold knee, with limited flexion extension, patellar mobility, the chances we have as rehabilitators to influence that and change it somehow throughout rehabilitation without surgery, which is a further insult, by the way, it is minimal. It is reducing. So the point is also catching it early. Range of motion is lost because of what we discussed. Fibrosis form within the joint. This means also contraction, adhesions that lead to contraction. So you imagine you have structures in the knee, like the suprapatellar pouch or the middle lateral gutters. These are anatomical spaces that should be empty, in which the synovial fluid should be the only thing present, and they start to progressively obliterate, partially or completely, because of this new tissue formation that is like gluing everything down. Also, the ingrowth of scar tissues in empty areas, such as the anterior interval. And when I mention that, I mean the area behind the tendon, the patellar tendon and the fat pad, and in front of the ACL and the notch. The area should be empty again. That tends to fill up with scar tissues, limiting then extension or flexion, depending by the area. And obviously, the surrounding tissues, the capsule, the tendons, the muscles also, they sort of get involved and into this fibrotic process. Why do we lose extension though? And here we start thinking about the clinical diagnosis. If you have a patient that does not extend, most probably something is happening into the anterior interval, involving also the infrapatellar fat pad or the Hoffa fat pad. Could be also that there is a limitation in the elasticity and pliability of the posterior capsule. This is something can be seen in MRI. The femoral notch can be involved in terms of the ingrowth of scar tissues. And we might have adaptive shortening or maladaptive shortening of the distal hamstrings or the gastrocnemius proximally, but that's just a consequence, a second level consequence. Mostly these are on top are the causes. And this, as we mentioned earlier, happens a lot. We have patients that are still losing more than at least 3 degrees or more of from the terminal extension after 1 year following anterior cruciate ligament reconstruction, which is crazy if you think about that. But that's not just how things are at the moment. Instead, if you are losing flexion, most probably there are adhesions in the suprapatellar pouch, so scarring there, which is not allowing the glide of the tissues. The capsule is no longer able to glide, hence you are stuck with a reduced flexion. And also, many other things can be involved, such as the overall thickening of the capsule, medial patellofemoral ligaments, and in general, patellar retinaculum and peripatellar tissues can become thicker, hence less elastic, and you have a more compression of the patella, which means less ability to bend the knee. In the end, obviously, the muscle in front, so the quad tendon and the quad muscle and the quad tendon and the patella tendon can become shortened, fibrotic, and actually, that's why we develop patella baja and patella infra. It's not a condition of the patella. The patella is a victim. The tendon gets the patellar tendon, sorry, gets thicker and progressively adaptively shortens, and this is dragging the patella down and inward. Here we start seeing the knee. It's just a drawing, obviously, but let's just focus on the fat pad again. This is a lateral view of the knee. It's a picture. It's a drawing. I'm sorry. But we should have this space all empty with fluid traveling in the joint, and the fat pad should be smaller than this. The fat pad is actually an organ by itself. There's also a publication, a nice study here if you want to check. This one well describing what happens, and I'm going to summarize this slide saying, think about Fat pad is an organ that reacts to inflammation and becomes oversensitized, which means gets bigger, thicker, fibrotic, and oversensitive, and gets also mechanically pinched when you extend the knee because it's invading areas where the fat pad should not get to. Actually, this is not the fat pad, this is the growing process of the fat pad through scar tissues. In general, walking with no crutches and loading too early can affect that, can make it worse. But long story short, again, it gets inflamed is because it's highly innervated, massively reacts also to inflammatory cells and also substance P, which is causing a structural change in the fat pad itself. Not just the fibrotic changes, but also nerve endings get sensitized, and the more they are in an environment, biochemical environment which is alterated by the peaking inflammatory cells in the area, the more they feel the pain and the more it gets sensitized. So it's a vicious cycle. Fat pad is quite often involved in arthrofibrosis. And this nice video, I know it's from cadaver, it's not the best, but it's actually explaining us what fat pad is. This is the fat pad here. You see the triangular structure in nature. When I play the video, if I can, there it is. You can see the fat pad seems to be linked to the tendon, seems to be the patella tendon and to the bone here. But look at this. As soon as you move, the fat pad detaches. So it's sort of a jelly, soft body that's in between, should be a cushioning body, but think about this, becoming bigger, thicker, and fibrotic and sticky, gluing down everything. Obviously, you have disruption in the patellofemoral mechanism. What happens is that when you see a knee with knee arthrofibrosis, you see something like this. And an untrained eye might say, hey, listen, this knee, your left knee is much more swollen than the other one. That's not swelling. That's the thickness of the knee, the capsule, everything gets bigger. And the patella itself, actually, the bone becomes bigger over time. That's a degenerative process. But the point is really the process the fibrotic process that involves the soft tissues around inside and outside the joint. So you can have knees that, unfortunately, after a total knee replacement, like in this gentleman's case, looks definitely deformed. And the more scar tissues we are looking at, the more probably we'll have an issue with range of motion. This is statistically speaking true, but we have a lot of patients with bad-looking knees. They can still function. And this is the first time I talk about function in this sense. The only thing we care with these knees is function. Sometimes the MRI looks not good at all, and we'll go through MRIs in a second, but the only thing we care is full extension and as much possible, as much flexion possible. And if the patella is mobile, even better. We will never have back a normal knee, but the only point we have to have in mind, the only goal is function, because certain things cannot be reverted. We just care about the functionality of the knee. So, we might end up with knees lacking extension and flexion, which is the case of the surgical knee, and it looks like it's less serious than it looks, than it appears. But extension lack here, considering the whole body weight of the patient is on his buttocks, we are losing here more than 10 degrees of extension, actually almost 15. And as you can see, the patient is barely able to bend. She's barely able to bend 90. So you can imagine the disability in the life of a patient this way. So high index of suspicion in the end is when expectations after surgery are violated, as we went through. Things are not just happening as they should and as fast as we were told, or if you're a clinician, as fast as you are expecting them to happen. Inflammation doesn't resolve. The knee is always warm, and there is stiffness, and the reaction is clearly happening, and is becoming chronic. It tends to last more than it should, and it never stops. And we need to rule out other causes though. So the point now is understanding what is knee arthrofibrosis and how we can diagnose it. So first of all, we need to refer to a classification. This is the best we have at the moment. It's the most recent one. I believe should be revised partially, but the point is, let's say 3 degrees of severity, mild, moderate, and severe. Let's look at the extension deficit. We should miss either for a mild arthrofibrosis, either 5 to 10 degrees of extension or bend a max of 90 to 100 degrees of flexion. And as you can see, the worse you get, the the more you are into a severe arthrofibrosis. But the point is, a lot of patients don't fit into this category. Sometimes they're just different. They still have arthrofibrosis. So this frustrates a little bit patients.